All right, good afternoon and welcome. Hi everyone, and thank you for joining us today. My name is Meg Beyer. I am part of the Managed Care Technical Assistance Center, otherwise known as our acronym MCTAC team. And I'm really thrilled to be joined today by some state partners who are going to review the COVID-19 program and billing updates for ACT teams. I want to thank you all for joining us. I know that there's a lot going on in our world today, and this is some really important and critical information at this time. So thanks for finding time to join us. Just a few logistics before we dive right in. This webinar is being recorded today. So the recording, along with the slides, are going to be posted to the MCTAC website in the next couple days. So if you want to share these with your colleagues, your staff members, you'll be able to do so. So visit the MCTAC website, check back for the recording and the slides if you're looking for them. We are going to be taking questions today. So while we have a brief amount of time for the webinar itself, if we have time at the end, we are going to try and answer as many questions as we can get to. So as such, I'm going to ask that you use the chat box functionality to chat in your questions. If you look at the right-hand side of your screen, you'll see the panel, and you'll see that there's a tiny little arrow to the right-hand side. If you can select host to chat your questions into, our wonderful MCTAC colleague Tara is collecting all of the questions into a centralized document so that we can review them in kind of a consolidated place towards the end of the webinar. So I just want to encourage you to chat in your questions, and as I said, time permitting, we'll be able to address some of them. For those questions that we're not able to address today, don't worry. We are sending them right off to the state, and they will be able to review them and kind of look at the questions that came in and offer their answers as such. And finally, I just want to thank all of our OMH colleagues and presenters today who will be presenting. We have Nicole Haggerty, Stacey Hall, and Peter Barnett with us on the webinar today who will be speaking to some of the content. So thank you to our presenters, and thank you to all of you who have joined. And with that, I'm going to ask Nicole if you want to get us started.
Thank you so much, Meg. We can advance the slide. Thank you, everyone, on behalf of the New York State Office of Mental Health for the important work you are all doing in this incredibly challenging time. Can you advance the slide? Okay. Given the nature of the COVID-19 pandemic, mental health providers have had to quickly adjust to dramatic changes in staffing, service delivery, and outreach. Community behavioral health providers offer a critical safety net, maybe now more than ever. As such, the Office of Mental Health has worked with the Department of Health and the Governor's Office to secure waivers that allow providers to deliver services in new and flexible ways, including the expansion of telehealth. The guidance cited in this presentation was issued on April 13th. However, the billing and documentation relief you will hear about is effective as of March 7th, 2020, the start of the declared disaster emergency. Okay. As OMH relaxes documentation and billing standards, we do also expect that programs will continue to maintain quality services and continuity of care to every extent possible. We hope that the relaxation of billing standards also supports agencies in maintaining current staffing levels. We ask that providers continue to support individuals and ensure access to essential services during the disaster emergency. Okay. Essential services are services that are especially relevant in the current environment. Delivery of these services do not require updates to service plans. Essential services are simply intended to support individuals' basic needs during the disaster emergency period. And with that, I'm going to turn it over to Stacey Hale to talk about how this affects providers of assertive community treatment programs.
Great, thank you. So to start to talk about services that we're looking at to be essential are things like medication, looking at assessment, prescription, delivery, dispensing, injection. Also, counseling, psychotherapy, treatment, everything that you guys do in your service delivery. Crisis de-escalation and crisis intervention, really helping to keep individuals at home and out of the CPEPs and hospitals. Substance use services, looking at harm reduction techniques, motivational interviewing, medication-assisted treatment, really thinking about what services don't individuals have now and what could be helpful. For example, I hear AA is doing online meetings, so making that available to individuals. Dissemination of COVID-19 related information and support of emotional and physical needs, including things like helping clients plan for food, cleaning or understanding how to disinfect living areas, mitigating the stress of isolation. Next slide. So these ACT team expectations are not billing requirements, but they're important aspects of the work that you do and things that even though the billing standards may have changed for this disaster emergency, it's still important to continue these areas of support along with the essential services. So things like morning meetings, which is really important for the individual, but also for the staff as well to help keep connected. And then outreaching individuals, making sure that people are getting the services that they need, and also having prescribers outreach attempts for getting in touch with individuals, even if it's not a medication management month or they don't need an injection, just making that attempt. Next slide. So important parts, we made some changes and flexibility around documentation requirements. So for existing recipients, comprehensive assessments and service plan updates are not required and may be postponed until the disaster emergency is lifted. This can allow you to work off of current existing service plans and provide services to ensure continuity of care. And it will also allow you to address needs which may be related to the disaster emergency, but not explicitly called out in the service plan. So this way you can do any kind of service that is needed at this time for the individual. Next slide. For new recipients, it's really important to the state that individuals in need of services continue to get them during this time. So we've made changes that allow for more flexibility to support new admissions. So things like initial assessments and service plans can be established via telehealth modalities, including telephonically. There are no set timeframes for when these are due. I would recommend doing like an immediate needs assessment and then a service plan based on this to start, something that's small. You're focusing on things like med management, health and safety, or acute symptoms, not something that's as full and complete as you might normally do. Signatures, including prescriber or recipients, are not required, but you should obtain verbal approval of the service plan and agreement to that, making sure you're documenting that. And treatment should commence immediately. And I would say through all of this, documenting and progress notes is the most important thing to make sure that you're continuing to do on any services that you're providing. Next slide. For the disaster emergency, we've also suspended the need for internal UR processes as part of an OMH requirement. To be clear, this is not in reference to managed care guidance. Each managed care organization will handle utilization management different based on their own policies. This is specific to OMH. Next slide. So this is the part I feel is important because the guidance allows for a reduction of billing requirements, but it is not to change the service delivery or lessen standards. What it's allowing for is flexibility. So you may have an individual who either doesn't have a phone or has few minutes on the phone or who generally doesn't do well staying on a call for long. And this will allow flexibility for those situations. You should not be cutting down services because these standards have been more flexible. We don't want to be going into charts afterwards and seeing really good contact with an individual and then all of a sudden it's cut down to 5 minutes 3 times. If you can still serve someone at the level of 6 times per month, and the person is benefiting from that, we don't want to see that changed. I think that's the most important message from this. It's about allowing flexibility around billing. So I will now hand this over to Peter.
Thank you very much, Stacy. My name is Peter Barnett. I'm with the Office of Strategic Finance here at OMH, and I would just pick up on what Stacy is saying and emphasize that the release of this billing guidance, which really reduces contact standards for the ACT program, is intended to stabilize provider Medicaid revenue during this disaster emergency, where enrollees obviously will not be available to participate in the program in the same manner that they have been historically due to social distancing, quarantine, illness, and and other exceptional factors. So it's our hope that these measures will help sustain ACT provider staffing levels and continue the capacity to serve clients during the disaster emergency. So this slide here is this reduction of minimum billing requirements, and under the revised guidance, all telephonic and face-to-face individual contacts may now be a minimum of 5 minutes to count as a billable service. Reimbursement can be made at the full payment rate, which is rate code 4508 for services provided to enrolled clients who receive a minimum of 3 contacts in a month, one of which may now be a collateral contact. Reimbursement can be made at a partial step-down payment rate, which is rate code 4509 for services provided to active clients who receive a minimum of 1, but fewer than 3 contacts in a month. And that 1 contact may also be with a collateral. So I think that's fairly straightforward. Let's move to the next slide, 13. So for clients admitted to an inpatient facility during the billing month, really these revised billing standards for the full and step-down claims will follow the same rules. And although it's not detailed on the slides, the rules for collateral contacts are in fact the same. Providers should use a rate code 4511 when there is a full month of inpatient admission. If we could advance to 14. So it's important to understand the requirements for billing modifiers for both telehealth and for claims under the disaster emergency. These modifiers are required to appear on the claim. So this just gives you a few examples. If the service is still delivered in person and under the existing minimum requirements, then there's no need to use a telehealth or a catastrophe disaster-related modifier. If a service is delivered via telehealth and the existing minimum requirements are met, then the GT, which is the ACT modifier, should be added to the claim. If the service is delivered via telehealth and the traditional existing minimum requirements are not met, but the minimum requirements under this revised COVID billing guidance is met, then you would add the GT telehealth and the disaster or CR modifier to the claim. Both would appear on the claim. There is also a reference document on the OMH guidance on COVID-19 webpage, which is entitled Telehealth Modifier Use for OMH Licensed and Designated Programs. The link to the guidance page, I think, is in the guidance document itself, as well as the webinar, and that file will provide a detailed rate code, procedure code, and modifier summary for use for all claims. So I think at this time we'll reserve the balance of the webinar for questions, and I'm going to turn it back over to Meg, I think, to answer any specific questions that were sent to our chat room.
So we've gotten a couple questions, so I'm going to try and sort through them. And we'll get to what we can manage, and what we can't, we will definitely send to the state. So please keep chatting your questions in. Our first question, so one of the attendees is asking, since the effective date is as of March 7th, 2020 for this guidance, are we back billing for March?
So this is Peter. I'll take that. I think as long as providers are meeting these revised standards for contacts for the month of March and have the documentation for contacts in the record, then they may revise their March claims and resubmit.
Okay, thank you. And just a little bit more, just another question kind of somewhat related to that. So one provider is asking, they submitted their attestation, so the effective date is this March 7th. They submitted their attestation later in the month of March, or on March 16th. So they're wondering if they can now count telehealth between the 7th and the 16th of March, or not between that time period before they submitted their attestation.
This is Nicole. I'm just thinking that one through a bit. It might help just for us to bring that back and take a closer look.
Sure.
I know the intention with telehealth, Meg, just so you're aware, is the intention is that providers attest to the state that they're going to be doing telehealth, but I don't think that there's a hard standard on the time frame around it. But I just want to get confirm with all the details that the person provided and respond back.
Great. So we'll make sure you get that info, Nicole. Don't worry.
Thank you.
Okay. Let's see. So this person wants to confirm that the provider can get partial payment if the only visit or contact we have for the month is a collateral.
Can you repeat that question, Meg? Sorry.
Sure, absolutely. So the question is, can the provider get partial payment if the only visit or contact that they have for the month is a collateral?
Yes.
Okay, great. All right, let me check this next question. Okay, so if a provider needs to postpone a service plan, is it due as soon as this ends, or is there time to catch up?
We're currently talking about right now internally how things will be lifted after the emergency disaster. So we'll likely have some more information coming out about that. But I would assume that it will probably be close to around that time. But I don't think we've made a decision on that yet.
Okay, got it. Okay, here's another specific question. If a recipient has 2 collateral contacts, but only 1 direct telehealth service with the recipient in a month, that would not be a full bill of $45.08, but a partial $45.09. Is that correct?
Correct.
Okay, correct. All right, thank you. Next, let's see. So someone is wondering if there will be a change in what counts as a collateral contact, like CR staff.
We have not changed the definition of collateral. So collateral would be any of the individuals you currently consider as a collateral for the individual.
Got it. Okay. Let's see here. Okay, here's another question. If a client receives enough services to bill for a partial month using the regular rules, but they can bill a full month under the emergency rules, can they bill the higher rate?
Yeah, that's correct. The provider may bill the higher rate under the standards here for a full rate code 4508.
Great, thank you. Let's see. So will a P note indicating review and agreement of a plan count ongoing past this pandemic?
At this time, the billing and guidance document that is out is specific to the emergency disaster. It can be something maybe that we would discuss in the future, but for now, it's specific to this.
Okay. And we've gotten a couple more questions. Thank you, Stacy. So in the meantime, we've gotten a couple more questions about attestation and when folks can start, I guess, considering the beginning of their process so if they submit it on a certain date, when can they consider their ability to start in terms of attestation? Would it be the date they submitted?
So if I could just clarify, Megan, maybe this will help answer a couple of the questions. The state initiated the allowance of telehealth and the expanded definition some time ago prior to this webinar. And so ACT teams could have been doing telehealth since that time, and the guidance specific to telehealth and the attestation process is also on our OMH guidance webpage that would likely answer the question around timing for that. The webinar today talks about services that are provided face-to-face or via telehealth, and the changes today reflect the billing and documentation allowances, much of which we understand, given the current circumstances, would be provided via telehealth. And the billing and documentation relief that is referenced in this document, effective March 7th, 2020, it is just that. That is the period of time that if providers are performing services and doing so under the current reduction or elimination of the billing requirements, that those requirements via telehealth or not would be in effect as of March 7th.
Thank you, Nicole. So a couple folks have chatted in asking about, whether the slides will be available. Yes, they will be available shortly and posted to the MCTAC website. So the slides along with the recording will also be available. If we're concerned about accessing them, we'll make sure they're available. Let's see. Okay, so this is a question, I think, about social distancing. And so due to social distancing, let's see here. I think this says residents. Some residents do not allow clients to come for incoming calls. I'm sorry, I'm having a hard time understanding the question. You know what, I might ask the person who chatted the question in to just clarify it, and I'll circle back. I'm just having a hard time understanding. So I'm going to jump to the next one, but if you can clarify, I'll be happy to jump back to that. Okay. All right, so here's another question. Some of our contacts are seeming to be limited to the discussion of COVID-19, and then the client will end the telehealth session. For these people who don't have an applicable health goal or objective on their existing service plan, should we be adding goals specific to COVID-19 so that we can link these sessions to billable goals?
No, that is when we talk about the service plans not needing to be updated, we really wanted to stay away from having multiple service plans that were completely COVID-19 specific, when really we want to make sure that, things kind of go back to the service planning process outside of this. So you are able to still write a note about that and bill for it. And I would just be explicit in the note to be clear that it is COVID-19 related and not in the service plan, but the need of the individual, and that will be fine.
Thank you. Okay. see here. So I think we've also gotten just some general questions about telehealth. And I do want to try and keep the questions more directed towards our more specific topic with ACT and the update around program and billing info. So if you do have questions outstanding about telehealth, I would direct you, and OMH partners, let me know if I'm incorrect in this, but there's a whole bunch of guidance on the OMH website that has a lot of information about modifiers, about more details about telehealth, and I would direct you there. I'm just trying to keep, yeah, go right ahead.
Also, Meg,
please.
I would just add that the email address that you are showing is also an address where questions can be sent to. I would ask that people check to see if the information is already available on the guidance site that you talked about. But if it is not a question that's been answered, that is an email address that you can send questions to, including for the discussion today.
Got it. Thank you so much for that. That's very helpful. Okay, so let's see here. I guess there's a question about a part of the presentation that talked about an increase in revenue in comparison to the previous month, and someone's wondering what is seen as an appropriate change in revenue.
Yeah, so this is Peter Barnett again. We are offering these revised billing standards for Medicaid really to help stabilize providers' Medicaid revenue in an environment where, you know, it's much more difficult to serve clients in a historical sense. And so it's our intention to preserve historic levels of reimbursements, again, to continue operations, to allow providers to maintain staffing and salary levels that are consistent with their operations. It is not our intent to provide a windfall to providers, and so we've reserved the rights to evaluate how claiming and revenue looks under these revised standards, and that is in part why this, you know, the disaster relief modifier is added to the claim, and to evaluate whether there were substantial or significant increases in revenue as a result of these revised billing standards, and to evaluate that on a provider by provider basis. But it is our expectation and the design of this reimbursement to really bring providers back to, you know, average or historical revenue levels rather than provide substantial additional revenue. And so that's what that note really indicates. And we're reserving the right to evaluate that after the emergency. That's helpful.
Thank you. So I think with that, I'm looking at time. There are a couple other questions, but I think, you know, we will send those back to the state for your review. I want to thank everyone who joined today, and especially our state partners who walked us through all this guidance. And with that, I just want to say thank you again, and I think that's the end of our time for this webinar today. And please send in your questions and stay tuned. We'll be posting the recording and the slides shortly to the MCTAC website.